Good morning, all. I'm Dr. Divya Mishra, working as Assistant Professor Pediatrics in the Department of Pediatrics, Lakshmi Narayan Institute of Medical Sciences. Today, we are going to discuss the care of a normal newborn. So, starting with the topic, what is a normal newborn? Any baby who is born with a normal expected weight, that is 2.5 kg or more than 2.5 kg, or the baby is appropriate for gestational age, that is baby's weight is lying in between 10th to 90th centile for the age appropriate, gestation appropriate weight. So any baby who is well more than 2.5 kg is appropriate for gestational age, not the short for gestational age or long for gestational age. Those baby can be taken as normal baby. Any baby who is term more than 37 weeks without any major malformation, some minor malformation which is not going to impair day-to-day activity like extra digits, club foot, these should not be counted, but any malformation which can impair the feeding regular day-to-day care should be taken as major malformation or might be requiring an ICU admission. Then there should be absence of any maternal illness like gestational diabetes mellitus, antepartum hemorrhage, which can impair maternal milk production, maternal status of postpartum illness, and the routine newborn care. Plus, these diseases may directly affect the newborn. Like, for example, GDM, babies who are born to GDA mother are more at risk of developing hypoglycemia. Babies who are born to a mother with antepartum hemorrhage are more at risk of developing perinatal asphyxia. So all the babies who are born to a mother without any significant illness that might interfere the normal newborn care feeding, or that is not going to put the baby at increased risk of any of the metabolic or any abnormality, can be taken as a normal newborn. Now, if the baby has required some kind of resuscitation at birth, that baby should be observed for some time by the healthcare professionals, and that baby we cannot take as normal newborn. Then some cause of the postnatal illnesses like RTS, sepsis, any of electrolyte disturbances, most commonly hypernatremia, hypokalemia, hypoglycemia, polycythemia. These require either an ICU admission or the close supervision by the healthcare workers. So these baby we cannot take as normal newborn. So in nutshell, what is a newborn? A newborn who is born as term baby more than 37 weeks with 2.5 or more than 2.5 kg is appropriate for the gestational age without any malformation, without any significant maternal illness, cried immediately after birth, and did not have any significant problem soon after birth. So those babies can be taken as normal newborn. In this session, we are going to discuss how to take care of the normal newborn during delivery, after delivery, at the time of discharge, and how to follow up. So this is the objective of today's session. Now, starting with what are the components of care? Soon after birth, establishment of respiration, breathing, crying is the most important thing which is going to affect the baby's long-term outcome. So establishment of respiration is the utmost important thing in the neonatal life. Then after birth, prevention of hypothermia, establishment of breastfeeding, prevention of any kind of hospital acquired or community acquired infections, and early identification and early intervention of the neonates who are at risk. So these are the important components of care. Now, what are the stages? From where we have to start? The preparation should be started before delivery, anticipating what we are getting, what we are going to get. If the baby is high risk baby, babies we are expecting as the normal baby, any maternal risk factor, how many babies we are getting, it is a singleton or twin baby, what are the risk factors, what is the condition of mother, depending on all the antenatal conditions, we have to prepare before delivery. This we will cover in some other video with the basics of neonatal resuscitation program. How to prepare before delivery, how to do immediate care at and after birth, and essential postnatal newborn care will be we will be discussing in this session. Now preparing for birth. So according to neonatal resuscitation program by American Academy of Pediatrics or Indian Academy of Pediatrics, we have to arrange some things, equipments arrangement, we have to do team briefing, we have to divide the expected events for which we are preparing, and we have to allocate all the persons their responsibilities. We have to arrange some equipments like the dry linens, pod clamp, clean pod clamp, vitamin K injection, properly functioning warmer. Then if the baby didn't cry, then the required resuscitation things like bag and mask ventilation, proper size mask, laryngoscope, endotracheal tube, all those things should be arranged before attending the delivery. The temperature of delivery room should be around 25 to 28 degrees centigrade. It should not be very chilled, it should not be very dry. And minimum one trained person in neonatal resuscitation should be attending the delivery. If we are expecting twin delivery, minimum two persons are required. And if the delivery is high risk, suppose it is a 25-weeker, 26-weeker, or the mother had cord prolapse, in those situations, we are expecting the baby might be compromised at some point and we might need two persons. So in those high risk conditions or in twin deliveries, minimum two persons are required. Otherwise, one trained person in neonatal resuscitation is sufficient. Now we have to arrange, we have to look for the area for resuscitation water with a functional warmer. The warmer should be kept in the manual mode with 100% heater output because we are expecting a baby is coming from the cold environment and we have to rapidly dewarm the baby. Now the contents for resuscitation kit. We should put suction catheter, 8 or 10 friends, suction machine, resuscitation bag and mask, laryngoscope with different size of blades, endotracheal tube 2.5, 3.5 mm. Then only few medications which might be required like epinephrine, naloxone, normal saline, and other things to deliver these medicines like cannula, umbilical vein catheter, three-way, normal saline flash syringes. All these things we have to arrange before attending the delivery. Now at birth, if the mother is delivering by NVD or by NSCS, we have to stand next to the physician to receive the baby immediately after birth. Or if the baby didn't cry, or if the baby has cried, we can wait for the delayed cord clamping. So soon the baby comes out, timing of birth should be noted by any person, and standard precautions and asepsis at birth has to be followed. We have to clean our hands, we have to take the dry and clean linens, clean tray, warmer should be clean, and we should not touch the OT area, the OT bed, OT instruments, we should stay away from those things. So standard all the aseptic precautions should be taken at birth. And the most important thing is the 5 cleans to prevent sepsis at birth. Now what is 5 cleans? This is the 5 cleans given by WHO and it should be strictly followed for attending any delivery, whether it is an institutional delivery, home delivery, everywhere it should be strictly followed. So what are the components? First is the clean hands. We should wash our hands prior to attending delivery. The clean delivery surface, the delivery bed should be very clean without any contamination, without any old linens or infected things. Then clean cut. We should have sterile blade, scissors, but it is one of the most important thing to prevent neonatal sepsis. So the thing what we are using to cut the umbilical cord should be sterile, blade or scissor. Then the tie. whether it can be a aseptic clean thread or the commercially available umbilical cord clamp, but it should be clean and sterile. Then the clean cord practice. Cord has to be kept clean. Nothing has to be applied. So revising all the 5 components. First is the clean hands, proper hand hygiene and wearing sterile gloves, clean delivery surface, that is clean and sterile towel to dry and cover the baby. We are conducting the delivery on the clean surface and we are receiving the baby on the clean, dry, pre-warmed linens. Then clean blade or scissors. So cord has to be cut with a clean and sterile blade or scissors. And then the cord clamping. Cord can be clamped with a clean, sterile clamp, which is commercially available in market, or some clean thread. Then after cleaning and cutting the cord should be dry and nothing has to be applied. Initially, so many things were recommended, povidone, iodine, but nowadays the cord has to be kept only clean and dry. Nothing has to be applied on the umbilical cord. So these 5 cleans are of utmost importance. Clean hands, clean surface, clean blade, clean tie, and clean pot. Now after receiving the baby, when the baby is born out of mother's womb, what is the warm chain? Baby's temperature should be maintained. The delivery room should be warm between 25 to 28 degrees without any draughts, without dry winds. All the windows should be closed and it should be maintaining temperature. Dry the baby immediately. The wet linens which we have removed received the baby, that should be removed. The preferable option is to keep the baby skin to skin with mother. If the mother has delivered by normal vaginal delivery, we can keep the baby on mother's abdomen. If the baby is born by LSCS, we can keep the baby on mother's chest immediately after receiving the baby and removing the wet linens. This is the best way to provide warmth to a baby. If because of any reason it is not feasible, then we have to receive the baby under radiant warmer in manual mode with maximum, that is 100% heater output. So the preferable option is immediate transfer of baby to mother's chest or abdomen. If the baby has immediate cry, or if not cried or not feasible, then we can shift the baby immediately to the under the radiant warmer. Now, after delivery, the clean chain, that 5 clean practices has to be strictly followed. Hand washing before handling the baby, exclusive breastfeeding, that is going to ensure no contamination. Keep the cord clean and dry. Do not apply anything. Use a clean cloth as diaper or napkin, and frequent hand washing after changing the diaper, napkin, or after any contamination. So this hand hygiene and asepsis has to be maintained. The baby was received in the wet linen and the linen was immediately removed and the baby is immediately dried. Preferably with 3 or 4 gentle strokes, we can roughly dry the baby, or preferably the baby should be immediately shifted to mother's chest or abdomen for skin to skin contact and initiation of breastfeeding. This is the best method to prevent hypothermia and to initiate early breastfeeding. If the baby is vigorous, is term baby, do not require any kind of resuscitation, baby should be immediately transferred to mother's chest or abdomen. Now, delayed cord clamping of umbilical cord for 1 to 2 minutes. In which cases we have to perform this, and how much delay we can do. So delay we can do from 1 to 2 minutes, and now it is recommended even up to 5 minutes. If the baby is vigorous, having good tone, cried immediately after birth, we should wait for the clamping of the cord. This extra blood which baby is getting from the delayed cord clamping is going to prevent many morbidities in the newborn. So delayed cord clamping is recommended for both preterm and term baby. Now cleaning the baby, clamping the cord. Stump length should be 2 to 3 centimeter, allowing some space, because once we apply the clamp, After that, the cord is expected to shrink for some length. So the clamp should not be immediately applied at the start. Some margin should be given for the area to shrink in the latter life in the first few days. Care of eye. Both the eyes should be washed with separate, clean saline swabs, and it should be clean from medial to lateral side. And the same swab should not be used for both the eyes, because in this way, if there is any infection, any chemical allergy, that will be transmitted to the other eye also. Then placement of identity band, which should be uh, showing the name of the baby, time of the birth of the baby, and preferably weight of the baby. Then UpGuard score should be recorded at birth. Now, what is the advantage of preterm babies delayed cord clamping? It is associated with reduced IVS and other morbidities. But most important benefit what we are getting from delayed cord clamping is the reduced incidence of intraventricular hemorrhage. Few minor side effects are there, that is like slightly increased predisposition to the jaundice, but these are only minor thing in comparison to the major significant illnesses like IVH, which we are getting benefit from the delayed cord clamping. Now, cleaning of the baby. Baby should be dried and cleaned at birth with a clean and sterile cloth, and it should be gentle. Only 2 or 3 wipes is enough to remove the blood and meconium. And we should be very careful to not remove the vernix caseosa, that is the white greasy material on the skin. This vernix is going to protect the skin of infant and help to maintain the temperature. It is going to be reabsorbed on its own after some time, within a day mostly. So we should be careful while cleaning the baby. Stroke should be gentle, 2 or 3 strokes, and only blood, amniotic fluid, and meconium should be cleaned. We should never attempt to clean the vernix caseosa. That is one good thing, one nature's advantage being given to the baby. Umbilical cord should be clamped at 2 to 3 centimeter from the umbilical stem, and we can use either commercially available clamp or a clean autoclave thread or a sterile rubber band. The stem should be away from the genitalia. At the point of cutting, it should not be so long to touch the genitalia. Then only we can avoid the contamination by urine or stool. Placing identity band is very important, showing the name of the mother, hospital registration number, date and time of birth, and preferably baby's weight. Now, what is UpGuard? UpGuard is the status with which baby was born and after intervention baby was received. So, UpGuard we can calculate at 1, 5, and 10 minutes. Okay. What are the components of UpGuard? UpGuard is an acronym. Roughly, we can correlate A for activity, P for pulse or heart rate, G for grimaces or the reflex activity, A for appearance or the color, and R for the respiratory efforts. Note down that it is not respiratory rate, it is respiratory effort. So, UpGuard can be given from 0, 1, and 2. If the activity is absent 0, some flexion is there at arms and legs, then it is 1. And if that is very good flexion at arms and legs, it will be 2. Heart rate, if absent 0, heart rate is present but less than 100, 1 point. Heart rate is good and over 100 per minute. The UpGuard, the scoring we will give for the heart rate will be 2. Grimacing or reflex activity. This is the response of the baby to our stimulus. If the baby is not responding at all, is completely floppy, then the score will be 0. If the baby has minimal response to stimulation, score will be 1. If the baby has prompt response to stimulation, score will be 2. Then appearance or the skin color. If the baby is completely cyanosed or pale, 0 score. If the baby's body is pink but the extremities acrocyanosis is there, 1. And if the baby's hands and feet are also pink, baby is completely pink, 2 score will be given. Respiration wise, if there is no effort, 0. If there is some effort, but it is slow and irregular. Apnea, gasping is there, 1 point. And if the baby is vigorously crying, there will be 2 points. So if the baby is born with good conditions, baby's upguard will be between 7 to 10. If the baby had mild depression, some intervention was required. Upguard we expect as 4 to 6. And if the baby came back severely depressed and even after intervention, if the upguard final upguard at 5 and 10 minutes is 0 to 3, that means the baby had significant perinatal asphyxia and the baby is in severe perinatal depression. So upguard is a retrospective thing. When we receive the baby, we will start the interventions as per neonatal resuscitation program. And at the end of 10 minutes, retrospectively, we have to assign the upguard at 1, 5 and 10 minutes, how the baby was born and how the baby responded to the intervention. Now coming to the care of baby immediately after birth. So what all things we have to maintain? One of the most important things, especially in the older areas of our country, to maintain warm air. Many of the babies will die of the hypothermia if we are not taking proper care of the baby. So baby should be properly clothed with the caps, sweaters, mittens, everything. Head is contributing to the maximum surface area. So head should be covered with proper clothes, caps. We can postpone the bathing, particularly for the small babies, preterm babies, till they become uh, term gestation, or even for the term babies, we can postpone the bathing for initial 5-6 days once the cord falls. Because bathing the baby will expose the baby to the cold environment for some time, some 10, 15, 20, 30 minutes, and that can be dangerous. So we have to be careful. Let the baby stabilize with the environment. Let the baby gain birth weight or let the baby gain as the normal 2.5 kg weight and let the cord fall. Then we can keep proper bathing. Before that, we can sponge the baby with lukewarm water or with the normal temperature water. Now, baby should be kept close to the mother. That is zooming in. It will not only keep the baby warm, plus it is going to promote the breastfeeding. It is going to increase the breast milk output. Then kangaroo mother care or kangaroo father care. It is suitable for the stable low birth weight babies. They are going to rapidly gain weight. They will be prevented from many kinds of sepsis and they have better neurodevelopmental outcome if we are giving kangaroo care for the stable newborns. It can be given by the mother or any of the family member. Then we have to demonstrate mother how to avoid hypothermia, how to recognize hypothermia early by showing that what is the core body temperature, what is the peripheral temperature, how is the baby's hands and feet. So these dangerous things we have to explain mother and we have to initiate breastfeeding as soon as possible, preferably immediately after birth by putting the baby on mother's chest. Now we have received the baby, we have stabilized the baby, weight should be checked. And first thorough examination should be done from head to toe to rule out any external congenital malformations and it should be recorded properly in the newborn case record pro forma. Breastfeeding and breast calling should be ideally initiated within first hour of life. That is the golden hour of life. In this time, baby will be maximum active. So baby can start sucking in the first hour of life. So this is the golden hour to start the breastfeeding. Routinely, we are giving vitamin. We have to give vitamin K injection to all newborns. If the baby is more than 1 kg, 1 milligram dose is okay. If the baby is less than 1 kg or 1.2 kg, 0.5 milligram is sufficient. After stabilizing, recording the weight, putting the ID band, and starting the breastfeeding, we have to communicate with the family, and we can explain the family what is we can show the baby to the family, to the father and other members, what is the gender of the baby, birth weight and the condition of the baby. So these things after stabilization, checking the weight, putting the ID band, we have to communicate with the family. And finally the baby has to stay with mother throughout if the baby and mother both are fine. This we have already discussed that umbilical cord clamp has to be put after 2 to 3 centimeter, and we can observe the cord after cutting for some 15 minutes. Do not apply anything, any bandage or anything to cover this area. This area should be naked to have a close vigilance that if any signs of infection, bleeding or anything is there. So after cutting the cord, we have to leave the stump uncovered. Breastfeeding has to be started within the first hour of life. Keep the baby in skin to skin contact with mother's breast immediately after drying. Help the mother in her first few attempts. Counsel the mother, train the mother, show her proper positioning and attachment, and give her some positive reinforcement that the milk output is going to improve. She will be doing very good job in feeding the baby. So we have to give positive inputs to the mother. Now, when to discharge the baby? A normal baby, which is not having any problem, should stay. That baby should stay in the health facility for at least 24 hours. Following criteria should be met prior to the discharge. The routine formal examination of the newborn has been performed and documented. The newborn is breastfeeding properly. Adequacy of feed can be determined by the passage of urine. Baby must be passing 6 to 8 times every day urine. Baby should be sleeping well for 2 to 3 hours after every feed. The newborn should receive immunization as per schedule. The mother is confident and trained to take care of the neonate. The newborn is not having significant jaundice, and the mother should be counseled about the routine newborn care and all the things, all the danger signs and everything. Mother has to be explained. So when the baby and mother both are comfortable, after a minimum observation of 24 hours, baby can be discharged after explaining all the danger signs to the mother and all the follow-up things, follow-up dates, and after training the mother how to take care of the baby. Now, what are the danger signs? Danger signs in the baby that should be explained to the mother and or the parents before discharge. If there is any difficulty in feeding, if there is any abnormal body movements, if there is poor activity, fast breathing, respiratory rate more than 60, labored breathing, chest indrawing, hypothermia or hyperthermia, temperature less than 35.5 or more than 37.5. All these things, family members should be vigilant. If any of the danger signs is there, the mother has to or the family has to report the healthcare facility immediately. Otherwise, if the baby is accepting feeds well, is passing 6 to 8 times urine per day, is sleeping well, activity wise the baby is well, no abnormal movements, then the baby can be taken care at home and regular scheduled visits baby can have. So we have to protect the baby from any hypo or hyperthermia. Umbilical cord should be kept clean and dry till it falls. Do not apply anything, any ointment, betadine, nothing has to be applied on the cord or nothing, no eye drops, nothing is required for the eyes. And the baby should be started on exclusively breastfeeding for day and night for at least 6 months. After 6 months also, baby should be having breastfeeding along with the complementary feeding. But for the initial 6 months, the breastfeeding should be exclusive breastfeeding. No other things, not even water or light water or anything should be given. Now, at the time of discharge and at the time of follow, what we have to measure, that is the anthropometry, weight, length, head circumference, chest circumference. Initially, all the newborns are going to lose up some weight, some 5 to 7% during the initial first 3 to 5 days. This is the loss of extracellular fluid. The baby should regain the birth weight by 7 to 10 days of life. Although preterm babies might regain the birth weight by 14 to 20 days of life, all the term babies usually should regain the birth weight by 7 to 10 days of life. After that, there should be steady weight gain approximately 20 to 30 gram per day in the first month of life. So this we have to monitor in all the follow-ups, whether the baby has regained birth weight after the initial loss. Now the baby is gaining adequate weight or not. Then length. With the help of infantometer, we can measure the length of the baby from top of head to the heel while with the fully extended leg. Roughly, a baby term normal baby should be having a length of around 45 to 50 centimeter, 46 to 56 centimeter. This is the average expected length for the normal term healthy newborn. Head circumference at birth should be taken, but after the molding and caput has resolved, the head circumference should be rechecked because it is going to be influenced by all these conditions. Average head circumference in the newborn is around 33 to 35 centimeter, and normally it is more than 2 centimeter from the chest circumference. How to measure? We have to place the tape above the eyebrows and stretch around the fullest part to cover the occipital prominence at posterior fontanelle. So this is the method to check for the head circumference or occipitofrontal circumference. Now chest circumference. Where we should check? We should check at the nipple line, and it is average between 30 to 33 centimeter, roughly 2 centimeter less than the head circumference at birth. So these are the components of anthropometry which should be checked at birth and it should be checked at the follow-up, especially the weight, to check whether the baby is having good weight gain, proper feeding, and other things are going well or not well. So on follow, what we are going to see. After discharging the baby, we have to call the baby for follow-up depending on the risk factors. We can call the baby after 2 days, 3 days, 5 days, or after 7 days. So in all the follow-up, we have to assess the growth and development. We have to assess the adequacy of breastfeeding. Then we have to early identify and manage the illness. If the baby is having, suppose, hypothermia, some breathing difficulties, apneas, poor feeding, some signs of sepsis, we have to early identify, diagnose, and manage those conditions. Then health education to the mother regarding the baby and maternal care. We have to provide proper health education to all the family members. Then we have to ensure routine immunization. First immunization we should be giving before discharging the baby, the birth vaccine, BCG, OPV, and hepatitis B. Then the next vaccination, when the vaccination is scheduled at around 6 weeks, we have to inform the family, we have to counsel, we have to tell them what are the vaccines we are going to give in subsequent visits. So routine immunization we should ensure. This is one of the important steps in the infantile care. So that vaccination is one of the cheap and cost-effective thing to prevent many illnesses, including diarrhea, pneumonia, tuberculosis, and so many of the infectious diseases. We should counsel mother for the exclusive breastfeeding for the initial 6 months without any other supplemental feed. And complementary feeding has to be started after 6 months completed along with the breastfeeding. At the time of complementary feeding, starting of complementary feeding, we can explain the mother how to start, how frequently to give, what should be the consistency, what items should be added for the complementary feedings, and proper family planning methods. We have to counsel all the family members, both mother and father, to give some space between the babies so that all the babies can have proper care. So these things we are going to ensure during the follow-up. Growth and development, feeding, immunization, any of the maternal concerns, social and ethical issues, and the spacing of family members. So this was all about the routine care of the normal newborns, starting before the delivery, at the time of delivery, post delivery, at the time of discharge, and at the time of follow-up. I hope this is going to be useful for all the mothers and all the family members who has attended this session.